Welcome to ICS 2020 online. My name is Giulio Santoro, and I am a consultant colorectal surgeon and the chief of the Tertiary Referral Pelvic Floor Center at Treviso Hospital, University of Padua, Italy. I am chair of this session entitled Bugs, Brain and the Gut, towards a better understanding of pathophysiology and management of neurogenic bowel dysfunction. The speaker is Anton Emmanuel. He's not with us at the moment because he is very busy in the hospital and he's trying to join us during the session. It's my pleasure to introduce him. He is a professor of neurogastroenterology at the University College London and consultant gastroenterology at the University College Hospital at the National Hospital for Neurology and Neurosurgery. His area of research interests include the gut neurophysiology, the etiology and management of functional gastrointestinal disorders of upper and lower gut, and management of gut symptoms in neurological and muscle disorders. So we are pleased to welcome all the delegates watching. Please use the live chat to say hello and to ask questions. And now we can start with the video recording.
Hello and welcome. My name is Anton Emmanuel, and it's my pleasure to be able to join you in this kind of virtual format as meetings are being conducted these days. And I'm based in London and I work in University College Hospital and Queen Square. And the title of my talk is As You See There. And my intention in this is to try and present an idea of how managing bowel dysfunction in patients with neurological disease is, number one, incredibly important because it's a highly prevalent and burdensome symptom. But number two, how the science of that is evolving to move away from purely empiric type therapies, which are successful when used carefully, to more potentially modern tailored therapies for the future. So if we think about why this is important, we've got to remember that the human gut has more neurons than the spinal cord. It's a highly nervous organ. And as well as that, the other thing that's distinctive about this organ is that it also has billions, trillions of bacteria, more bacterial cells in your gut than there are in the rest of your body put together. So this is a complex mixture of the external environment as well as the internal environment, and that internal environment co-opts what your nervous system is within your gut, but also what bacteria you harbor and allow to reside, and the external system being what you eat and what emotional factors play upon this. So this complex relationship between what you put into the lumen and how the nervous system of that is controlled is part of what, number one, gives us an opportunity for the future, but number two, actually makes that a very difficult scenario to improve, because one thing being pushed up here will make the other thing worse over there, and so on. So this is something which is going to be an exciting area to work in, but answers will probably be slow to arrive. So why are we interested in this? We're interested in this because this is a highly prevalent problem for our patients. If you look at the prevalence of constipation and fecal incontinence, and the colored bars show the prevalence in spinal cord injury or MS, you can see how often this occurs. In over half of patients are constipated in either of those conditions, and again, over half with fecal incontinence. And this compares with the population prevalences of 3% or so of fecal incontinence and 10% or so of constipation. So highly prevalent problems. And not only are these very common, they're also enormously burdensome. If you look at the impact of bowel dysfunction, a couple of studies, this is Michael Camm's definitive one from 20 years ago now, looking at ask patients to rate the higher the number, the more severe the limitation. Bowel function rates number two in terms of the things that limit people with spinal cord injury, and from our data, number one in terms of patients with MS regarding bowel function as their biggest nuisance. So really prevalent problem. And if we begin to think about things we actually know about, so here's some data looking at motility in the gut, and I presented by looking now at the gut and working backwards to the nervous system, if I may. This is data on a healthy individual, and what you see is over a 24-hour period from 2 o'clock one day to 2 o'clock the next here, a probe which has been placed via the rectum all the way through the bowel, and multiple pressure points throughout the bowel, measuring pressures shown as vertical axis here. And what you see is propagated peristaltic contractions, which sometimes come all the way down to the anus and cause a bowel action. And these propagated contractions cluster after lunch, after dinner, and after breakfast. And when you go to sleep, your bowel goes to sleep. That's normal. Well, here's a patient with slow transit in relationship to spinal cord injury, and you see the picture is completely different. There is no peristaltic activity. There's much more retrograde activity, these red waves. There's activity at night, and you can see why this patient would have profoundly slow movement through the gut. But we must also think about that movement through the gut as being correlated with emptying. We mustn't just think of everything as being a neurologically and autonomically mediated contraction through the gut. There is also this issue that bowel evacuation depends on transit. If you look at this figure from the same set of data, beginning at time 0 where you have a bowel action and going back in 30-minute intervals along here, what you see in a healthy individual is that in that half an hour before a bowel action, there's lots of those propagated green contractions, whereas in an individual with slow transit, you don't get that. So there's a relationship between transit through the bowel as well as evacuation. The two things aren't opposite ends of the spectrum. They are related to each other, and you can see, of course, how the voluntary control of defecation has a conscious neurological element, which has to interplay with the subconscious autonomic element of transit through. So this is complicated. And if you look at this in the graphic term, this is a scintigraphic study, healthy individual in the top 2 panels before and after a bowel action, so radiolabeled stools, and you can see that when a person has a bowel action, they don't fully clear their rectum. In fact, some of the content from the left side comes into their rectum, but what they actually clear after a bowel action is a lot of the stuff in the sigmoid and some of the descending colon, which comes out or fills up the rectum for the next bowel action. Whereas in a spinal injured patient, you don't see any of that. When they clear their bowel, there's very little actual clearance of their bowel. They're just emptying out a tiny bit of their rectum, which is emptied out, but there's lots of the content remains in there, hence the reason for those symptoms of constipation and then potential leakage and fecal incontinence. And how have we classified that? Well, historically, we've taken a very simplistic approach to this, if I'm honest. We've talked around things having a supraconal type problem or a chordoequina type problem in spina bifida or chordoequina lesions. And there is some truth to this. So certainly patients who have an injury or disease like MS or whatever else above the level of the conus will tend to get a very high tone lumen. The gut throughout, but also the rectum become very high pressure. Sphincters become areflexic. They don't coordinate with rectal tone. And high pressure, so often patients can't void. They don't transit content through because this high tone bowel doesn't peristalse as well. And when it does, content does get down there, it doesn't coordinate with sphincter relaxation. Whereas in contrast, the more typical pattern of a chordoequina type patient is to have a flaccid bowel where the rectal and the whole gut tone is flaccid, and the anal sphincters tend to be of low pressure. So these patients tend to soil more. They tend to accumulate stools in this large voluminous rectum, which then leaks out at inappropriate times. And whilst there are certainly cases where this kind of very clear distinction can be drawn, there's lots of overlap in terms of this, partly related to autonomics, partly related to enteric bacteria, and partly related to the fact that no injury is, or most injuries are not that clean. There's often some obfuscation and furriness around the edge. So if we move to the clinical scenario, one of the first things I'd like to say is that don't just think about patients coming to tell you they're constipated. This is a complicated slide of work we did in the multidisciplinary group to try and help patients or help healthcare professionals work with patients, and we went through levels of assessment and thinking of causation and thinking of how you would approach this nutritionally and then by investigation along the rows. And the columns reflect different symptoms clustered by upper gut symptoms, reflux and nausea, abdominal symptoms, pain and bloating, and then bowel symptoms. And what I want to point out is not the detail of this, but the fact that that the bulk of what that first slide was meant to show, sorry I've skipped over it, was that patients' constipation underlies the symptoms for all of those, whether it's upper gut symptoms, whether it's distension, whether it's vomiting, whether it's reflux. We've got to exclude constipation as the first thing. That is the first line at the very top of that slide that I flashed over. I apologize. Now, how do we assess patients in the clinic? We're strong believers in diary because a memory of a history is not very good in this kind of chronic situation. So being able to give a diary of urge and diet and soiling and laxatives taken and digital assistance, that's quite helpful to give some granularity to the consultation. We ask patients to use things that they feel comfortable using. Patients seem to, in the UK, find this easier to discuss than actually talking about their stools more directly. And we know that stool consistency correlates with transit. And this is a very well used metric in the literature in neurogenic papers. But the most commonly used neurogenic measure is the NBDS, the Neurogenic Bowel Dysfunction Score, developed by Klaus Kroh and colleagues, an outstanding group in Aarhus in Denmark. Very simple. Patient can complete these 10 questions. You get a score according to what you complete, which gives you a score of between 0 and 42. And what they've also shown is that you can correlate these score tiers, which then relate very closely with quality of life measurements. So in other words, you have a symptom score as well as a quality of life assessment from this. And we typically classify this into very minor, moderate, or severe impairment. So this is a gold standard that's been used in a variety of neurological diseases. And if we stay in the clinic, one of the further things to recognize is that we must think about this presence of bowel dysfunction in patients who have constipation and incontinence, but also if they have other non-specific GI symptoms, bloating, reflux, etc., but also consider it in terms of patients we're looking after with bladder dysfunction. This is data from the North American group that you're all familiar with, showing in pale blue the bladder scores and red the bowel scores. And what it points out is that in patients with neurogenic bladder, there's a high prevalence of bowel symptoms. And if you look at it the other way around from another North American series, in patients with neurogenic bowel symptoms, there's a high prevalence of bladder dysfunction. So it makes the point about seeking out these patients because they can be helped. Now, we then move through what we actually understand about the continence mechanism. I hope we've now explained how this whole situation of rectal transit colonic transit causes rectal filling. Once you get the distension, you get that reflex relaxation of the sphincter, and when that is an appropriate social time, you're able to then void, whereas when it's inappropriate, you contract the sphincter and maintain continence until you do need to. And gradually, as the pressure in the rectum fills up with more content coming down, if you have chosen not to void, eventually that process becomes bigger than you can resist. So that's a simple mechanism, which I think we've gone through in a little bit of detail. And you can see, therefore, where conscious loss of nerve sensation can cause attenuation there, as well as the subconscious autonomic or potentially enteric bacterial factors can contribute to that. I want to keep this as an overview to inspire you to go and read further if you wish, rather than to try and go into detail. But I'm very open to please emailing me or asking me questions at the end of the session. And of course, we must remember that there's an interplay between bladder and bowel. We're all very familiar with the kind of spinal urethral reflex, sphincter reflexes, but must also remember that there is a contribution via the dorsal horn, both to and from rectal filling and anal sphincter function. So it's important to put this neurophysiology into context and how that spinal level reflex can be augmented by the two systems working harmoniously or disharmoniously in some cases. So when you move to therapy now, we've had 10 minutes talking about the physiological background. How about therapies? We've had this notion that there's a kind of a conservative set of approaches with diet and fluid, using laxatives in the context of altered lifestyle, encouraging and training patients to get into a routine with managing their bowel, using digital stimulation and suppositories in an appropriate way. And then for those patients who have sensation preserved, using biofeedback. And then we moved on to the idea of then saying that as a bridging therapy, if that doesn't work, moving on towards transanal irrigation, which I'll talk about more in a while. And then there are the less used therapies, including neuromodulation, which I'll touch upon briefly, and ultimately possibly even stoma surgery. Now, that idea of a pyramid we've slightly fallen out of love with, because it seems to imply that everyone has to progress up towards the top of the pyramid, which of course is not the case. We want to keep people in the conservative realm, and what we try to do is do more of a pathway here, and the larger the font, the more prevalent the abnormality and how it's used. So more patients are using conservative therapies, moderate number use irrigation, and a very small number go on to stone formation. And at the center of all this decision making is the patient's quality of life. So we don't say you must do irrigation or you must use laxatives. We tend to try and tailor it according to what the patient's situation is and what their aspirations are with conservative therapies. And this paper by Maureen Coggrave outlines what those therapies are, and I don't wish to necessarily go through it in detail other than to recommend that you do look this up, because it just gives you the idea of the lifestyle things that can be used and the evidence base for them, how prevalently they're used, and how to advise using them. And then as you step up to which patients use suppositories and enemas, and the importance of creating a regularity and a pattern to bowel opening to obey the urge and try and get into a routine of balancing diet with urge and void. And laxatives are a whole talk into their own right, but we try to summarize the data which in this one slide about laxative use. Not all laxatives are the same, and we very much try to tailor which laxative we use based on the evidence according to what the patient's particular symptom is. And again, it's not my purpose to go through this in detail with you, but to try and excite you to look further and certainly use these slides if that helps you to help treat the patients you're looking after. Irrigation then. So we have these different systems. They all comprise the same principle. A device which goes into your bottom end, which is single use, connected to some tubing based on a reservoir, and then a pump function which allows you to drain the reservoir into the bowel via that. And you can have this via a catheter system, or you can have it via a cone-based system where the patient holds that cone in place. Here the catheter has a balloon, so that balloon can be inflated once in situ to maintain position. Even if there isn't good body balance or hand function, you can still use that, whereas this requires greater hand control and balance, sitting balance, but of course is a smaller and less cumbersome device. And there's all sorts of manners of device. My purpose again isn't to present details on irrigation in terms of different devices. That's a whole talk in its own right, and this is a very exciting area of huge amount of research ongoing. But for those of you who are less familiar with irrigation, just to present to you the data about it, this is the definitive study from about 15 years ago now, showing that if you compare standard bowel care, this is a randomized controlled trial, a really important definitive landmark study with transanal irrigation. You see that we improve scores significantly in terms of constipation and incontinence, and the neurogenic bowel dysfunction score, the NBDS, which I mentioned, improves in irrigated patients. But also the metrics that matter to patients: less time spent on toileting, less time spent in the bathroom as a whole, and for reasons that we're still exploring, many fewer UTIs. There's a significant reduction in UTI prevalence, which we are still understanding. And with time, since that first presentation, we've now recognized that we can use it in post-surgical scenarios, which are increasingly prevalent, even in functional disorders, although I'm a bit more cautious personally in that scenario. But a whole collection of neurogenic bowel dysfunction, spinal cord injury, spina bifida, chorda equina, multiple sclerosis, Parkinson's disease. The menu is gradually broadening. And why do patients start it? Most commonly it's because their current green tier bowel regime of laxatives or suppositories isn't sufficient. Sometimes it's because they're having adverse effects with those suppositories, and sometimes importantly patients want to be independent of their carers. They want to be able to manage their bowel on their own, and with the right choice of equipment, irrigation can allow that. And what do we see when we irrigate? I've shown you these scintigraphic studies before. This is a spinally injured patient before. What you can see is that they clear out their entire left colon and rectum. So when you have a good irrigation, you get a proper clearance out of that entire left colon. So it does create a much better emptying, and patients will often only do an irrigation every second or third day. We've done some long-term data from our center looking at health economics, showing fewer hospital admissions, much less stoma surgery. I think I've already shown you some of that data in outline. Fewer UTIs, which also we presented some of that data on earlier, and even fewer consultations with specialists and primary care. And there are a variety of things we can do. We tailor the therapy to the individual. We know that it takes some time, and we can use a variety of adjunctive methods to try and optimize therapy. This is a whole talk in its own right, but I want to excite you that there are things that can be done rather than go through the detail. That's how I see this talk. Now, what are the costs of this? Of course, we worry about perforation. If you're putting a device into the bowel on a repeated basis with a patient doing it, they can cause trauma. And this is the published data on perforation rates, to the best of our knowledge. And what you see is that there's a set of people who perforate early on when they first irrigate. And what it transpires, these are the ones which are avoidable. These are patients who weren't properly trained or used kit inappropriately or used it too soon after an operation, say, when their anastomosis, mostly in functional or post-surgical patients, hadn't formed. These are errors and they should not occur. They are usually medical errors or patient-related errors. And with advances and with training, we're stopping that from happening. But there is a late cumulative set of cases which are not cumulative. And what it boils down to, if you look at the number of units sold by the number of perforations that we identify and report, it seems to me that there's about a 1 per 500,000 perforation rate. So there is a risk, but to put this into context, if you compare this with the risk of perforation from a colonoscopy, which we tend to quote as 1 in 1,000, 1 in 500,000 is a relatively more modest risk, but we must certainly warn our patients about it. And when we do irrigate patients, we've got to remember that not everyone will respond forever. But the patients who do best are in the purple line here, those with neurogenic bowel dysfunction. They're the ones who tend to go on the longest. So in the neurogenic population who we're talking about today, if you are still able to, if you start the start of irrigation, you can quote patients a 60% chance that they'll still be irrigating at 5 years. And if you're still irrigating at 2 years, you tend to seem to be going on term with it. Does it cause dysreflexia? Well, here's some data from Pierre Farburg and colleagues in Aarhus again, comparing transanal irrigation in the white bars with digital stimulation to void and bladder filling as a comparator. And what you see is that the degree of systolic blood pressure rise is least for irrigation. So it doesn't seem to cause much by way of dysreflexia, certainly compared to digital stimulation, which is reassuring. And the data that's accumulated has been the subject of a nice appraisal 2 years ago now, showing that this is regarded now as a cost-effective therapy, providing patients are trained. So it does reduce the severity of constipation and incontinence. It does improve patients' independence and dignity, but patients have to be carefully trained. They can't just be given the device to treat themselves. So we need to set up a service to train them, and it seems to have a cost-effective benefit on that. What else is there that we can do? Well, there's the Malone enemas, which is where the appendix is brought out onto the abdominal wall like a little dimple. That can be catheterized once every 3 or 4 days, and then a litre or so of water flushed through. It takes about an hour or so to irrigate the entire bowel out, and then the catheter is removed and the patient is continent. It's a continence enema because the appendix is a one-way tube, so nothing leaks out. It doesn't need a bag or a plaster or anything. And patients at whom responds, they swear by it, and as you can see, it causes a complete clearance of the entire bowel. But it seems to work better in younger patients than older, and with time the stoma, the appendicostomy, does tend to close over with time. But patients who like it absolutely love it. But as I say, there are problems which can develop in the longer term, but as a holding and a bridging measure for several years can be very useful. Hold, and I'm really grateful for your attention and would thank all the colleagues who have done all the work that's been presented in-house. Thank you very much indeed for your time. All the very best.
Okay, so I hope that you enjoyed this very fascinating presentation. Unfortunately, we are sorry because Anton cannot be with us in person today, but just want to make a brief comment. In his talk, Anton focused on the physiology of bowel motility as it affects clinical presentation, how to assess bowel function in the clinic, a management pathway, maybe very complex but very important for neurogenic bowel function dysfunction symptoms, and then risk and benefits of transanal irrigation, and the future and the rare neuromodulation and surgery. So I think that this very interesting field needs more investigation in the future, just to find out a new solution for neurogenic bowel dysfunction. So at the end, I just want to remind, please leave any comments or questions for him in the chat, and we will make sure that he sees them. Again, thank you for watching, and you can view more live sessions by looking at the program. Thank you and bye.